Okay, good evening. So today our discussion will be about physiology of aging. So before going to the topic as such, just a brief introduction. So whenever someone asks you about what is aging, always we think about the number. So age more than 65 is generally considered to be aging. But is aging really a matter of number? May not be. Because imagine a child growing up and becoming an adult. That process is not called aging, right? So what is actually aging? Aging is a progressive process that converts young adults into older adults whose deteriorating structure and function leads to progressively increasing risk of illness and death. So this is a definition taken from Geriatric's textbooks and Harrison's textbook of medicine. Every word is important. So aging is a progressive process. It keeps on going. It's not a static one. So what happens because of this progressive process? There's a deteriorating structure and function, right? What happens because of this deteriorating structure and function? They are at increased risk of illness and death. So this is what I was telling. Aging is the opposite of development. A child becoming an adult is called as a development, whereas a young adult becoming an older adult is called as aging. It is not just the number, because changes in structure and function happen in the body, which makes them prone to illness and death. This is what we are going to discuss in this entire lecture. So I told you aging predisposes to death. So a name is given for that. It's called Gompertz Mayhem law of mortality. As the number increases, as age increases, people are at increased risk of death. So you can see in the graph. Young children are at risk of death. Similarly, as the age increases from 20 to 40, you can see a steep rise in the risk of death. Okay, so having this definition in mind, we can classify phenotypes of aging into three phenotypes. So how all aging can manifest? One, as I told you, aging is a risk of diseases. So patient who's having aging or an elderly person may have multiple diseases. Example, he may have diabetes, hypertension, cancer, etc., where age is a predisposing factor of all these. It's called multimorbid age. Imagine another elder who doesn't have any of these diseases, but he has some other syndromes. So those syndromes are called primary age-related disorders. Example, dementia. Dementia is something called memory loss, something like memory loss. Sarcopenia is reduced muscle mass. Frailty is something like weakness. Osteoporosis is reduced bone mass. Urinary incontinence. These are typical for old age. These do not occur in young individuals. But as aging occurs, these normally occur as a part of aging. So these are called age-related diseases. This is called aging syndrome. If they do not have the diseases and if they do not have the aging syndromes, it is labeled as healthy aging. So these are phenotypes of aging. They may have diseases. They may have the age-related syndromes mentioned, or if they don't have any of this, it's called healthy age. So why we should be aware of the normal changes of aging? As I already told you, structural changes occur, functional changes occur, that predisposes elders to illness and death. Why we should be aware of this? Because we are professionals with public contact. Many a times public come to us, they ask us, my father has this symptom. Is it due to aging? So only if you know what is the normal change of aging, we can address that question. Also, we are caretakers of elders ourselves. So we should be aware of what all happens in aging so that we can manage them confidently. Also, we are future elder cohorts. So this is what we are discussing. As aging occurs, both structural and functional changes occur in the body. Example, I'll just tell one structural changes which occurs at the cellular level. As aging occurs, the number of cells in the body reduce. To compensate for that, cell size increases. Okay, so there's a reduced cell number, but there's an increased cell size. It's called hypertrophy. Please remember this. This will come throughout this class. Also, what functional changes occurs in the cellular level is the cellular multiplication. As you know, cell divides during growth. But as aging occurs, the cellular multiplication reduces. That is called replicative senescence. Senescence is aging, replication is division. So division gets aged. That's what it means. So among these structural and functional changes which occur with aging, some changes are normal. We need not remember them much. Example, there's some change called increased collagen cross-linking of joints. As aging occurs, a protein in the joints, collagen, becomes increasingly cross-linked, which you need not remember because it's a normal change of aging. It doesn't predispose to disease. But some changes predispose to disease. Example, a protein called amyloid deposits in the brain. This leads to Alzheimer's disease. Right? So we are not going to bother about changes which are normal. We only want to know the changes which predispose to disease. We have to differentiate. So another concept, there are few numbers which you have to remember. Telomere shortens at 1% per year after 30 years of age. So what is a telomere? So you know the chromosome. Telomere is the end part of the chromosome, the one which is given in blue here. Normally, as aging occurs, the telomere shortens. You can see here in a 1-year-old, telomere is quite long. In 30 years, it becomes short. In 60 years, it becomes even short. So how the telomere shortens? It shortens at 1% per year after 30 years of age. So why this telomere you should be remembering is one of the theories of aging suggests that telomere shortening is one thing which predisposes to aging. As telomere shortens, chromosome becomes unstable, the cell dies, which leads to aging. So other changes which occur at aging are systolic BP increases by 5 mm per Hg every 10 years till 60 years and then by 10 mm Hg. So systolic BP increases. DLC is diffusion capacity of the lung for carbon monoxide. We'll discuss that later. Decreases by 5% every decade after 40 years. So some changes occur in the lung, which impairs gas exchange. Muscle mass decreases by 1 to 2% year after 50 years. The decrease in muscle mass is called sarcopenia. Remember this term. Muscle strength decreases by 3 to 4% per year. It's called as dynapenia. This term also you should remember. Then what happens to the bone? Bone mineral density decreases by 0.5% every year after 30 years. This leads to osteopenia and osteoporosis. Renal blood flow decreases by 10% per decade. GFR decreases by 10% per decade. After 60 years, brain mass decreases at 1% year. These are just few numbers. We'll come again and again to this one. I'm just giving a brief introduction. So how will we go from this point onwards? So we just discussed that some changes occur in aging. Some may be normal, some predisposed to disease. And some predisposed to disease. So this is how we will approach every system. We'll discuss a particular system, what happens in aging, why that change happens, and how to differentiate a normal aging, healthy aging change versus a disease process. That is most important. And as future elders, we must know how to reverse or cope with the change. This is our approach. So these are the systems which we'll be discussing today. For a starter, we'll see what are the cellular changes which occur. We just started it in the first slide. As I told you, there is something called increased collagen cross-linking. Some proteins deposit in few structures like amyloid plaques in the brain. And as cells get exposed to glucose, advanced glycation end products occur. There's increased fat deposition. And as I already told you, cell number decreases, but cell size increases due to hypertrophy. These are some of the structural changes. What are the functional changes which occur? We have discussed one functional change earlier. Reduced cellular reproduction, and cells also have reduced apoptosis. That's called replicative senescence. Cells don't get produced, cells don't die. Apoptosis is programmed cell death. Cells don't get produced, cells also don't die. So, and as people age, there'll be increased exposure to risk factors. We all will be exposed to infection, we all be exposed to smoking, we all will be exposed to reactive oxygen species. So if you live for a longer time, you'll be exposed to the same things again and again. That leads to many changes. And there's decreased ability to repair DNA. As I already told, as telomere shortens, the genome becomes unstable. One of the tendency of the cell is to repair itself. But as aging occurs, the ability to repair DNA gets reduced. So again, this leads to further accumulation of damage. And there are changes in calcium signaling with age. There's something called low-grade chronic inflammation with aging. That's reduced immunity with aging. We'll discuss that. So these are the cellular, structural, and functional changes happen. Because of this, what happens? Because of all these changes, they are at increased susceptibility to cancer. So suspect, there are few pathological features which occur in cancer. Many of the features discussed occur in cancer. For example, reduced ability to repair DNA is one of the feature of cancer. Right? Reduced apoptosis is one of the feature of cancer. Chronic inflammation is one of the feature of cancer. Same thing occurs in aging. So aging predisposes to cancer. That's so. Whenever an elderly person presents with few doubtful symptoms, we should always suspect cancer. Example, epigastric pain with loss of appetite. We should not suspect gastritis. We have to suspect CA stomach because they are prone for it. Similarly, back pain in elders should not just be told as a disc problem. We should suspect a cancer, a myeloma or secondaries. So because cancer is so common in old age, beyond a particular age, we have to screen for breast cancer, cervical cancer, colon cancer, prostate cancer whenever it's appropriate. Right? So this will be our approach to the entire class. We'll be discussing the change which occurs and why we should know the change. Okay, so similarly, we'll discuss about the changes in endocrine system. Endocrine system is all the glands, pituitary gland, thyroid gland, including the sex organs. So as aging occurs, what happens? So we all know females go for menopause, men go for andropause. Because of this, the sex hormones get reduced. So estrogen and androgens reduce with aging. There is reduced vitamin D production as well as reduced vitamin D action. Remember, vitamin D is also considered to be a hormone. Vitamin D deficiency predisposes to osteoporosis. Melatonin is a hormone secreted by the pineal gland. Melatonin has a function in differentiating light and darkness, and it helps to induce sleep. So with age, as melatonin reduces, they are prone for insomnia. We see many elders having a difficulty in sleep. So these hormones get reduced. Few hormones increase. They are norepinephrine and cortisol. These are stress hormones. They cause some changes in the body. What happens to the sugar level? There's a slight increase in fasting sugar level. That's why elders are prone to develop diabetes. And there is slow return of glucose level to normal following glucose load. Fasting sugar is high. When they eat some food, sugar spikes up again. It comes back to normal slow. And atypical presentation of endocrine diseases is common. We all know that hyperthyroidism presents with palpitation, tachycardia, etc. Hypothyroidism presents with depression, dullness, etc. But in elderly individuals, hyperthyroidism presents with depression. That's called apathetic hyperthyroidism. Right? So why we should know is this is the applied aspect. As I already told you, vitamin D is produced from the skin. Vitamin D production is reduced in the skin. And vitamin D gets converted to vitamin D3 in the kidney normally. So that is also reduced. And there is secondary hypoparathyroidism because of reduced calcium. Secondary hyperparathyroidism. So why? Since vitamin D production is slow, action is slow, elderly individuals should be given vitamin D. So daily administration of 600 units of vitamin D is recommended in adults more than 50 years of age. This is the Endocrine Society guidelines in 2024. So how does this help? It helps not only for bone strength, it also helps in muscle strength. When bones and muscle become strong, it prevents falls. And there's some association with cardiovascular malignancy, autoimmune, and infectious diseases. Okay, we have finished one system, endocrine. So hematology. So this is how the normal hematology works, the blood cells work. In the bone marrow, there's something called pluripotent hematopoietic stem cell. It grossly divides into two lineages, the myeloid lineage and the lymphoid lineage. Myeloid lineage gives RBCs, platelets, and neutrophil, eosinophil. Okay, so this one contributes to the innate immunity system. As you know, neutrophil monocytes, the dendritic cells help in the innate immune system or the first line immune system. The other lineage is the lymphopoietic lineage. So pluripotent stem cells become lymphocytes. Lymphocytes help in specific immunity. So what change happens in aging? So instead of producing two lineages, in aging, myeloid lineage is more often produced. That's called myeloid skewing of hematopoietic stem cells. Because myeloid cells are produced more, they are more at risk of developing myeloproliferative disorders like blood cancer, CML. They are more common. Since myelopoiesis is more, the lymphoid lineage production is less. So the immunity is reduced. So these are three things which happens. Myeloid lineage gets increased, lymphoid lineage gets decreased, and the effects of that. So this is just a table. Just follow what I'm telling. In younger individuals, lymphopoiesis is more common. So if you see the blood reports of small children, their lymphocytes will be high, which is normal. But if you see elderly individuals, they have more of neutrophils. It's a normal phenomenon. So we are not discussing the other things. So because of this, there's something called changes in the innate immune system. So innate immune system is a non-specific immune system. So what changes happen is there is increased amount of inflammation or increased amount of non-specific immune response. So you would have heard about cytokines. There's increased amount of interleukin 6 and TNF alpha. Interleukin 6 is called cytokine of geriatricians. There is increased CRP, and because of that, there is increased clotting factors. So these are things which occurs in the inflammation. So why it occurs? As I already told you, inflammation is a non-specific immune response to a pathogenic agent. We have discussed first, one of the functional changes which occurs in aging is people are exposed to chronic infections, reactive oxygen species, etc. So because of that chronic exposure, they keep on having inflammation. Also some hormone changes because of reduced estrogen and reduced testosterone. This increases IL-6 levels. And I told about cellular senescence, reduced apoptosis. Cells are not produced, cells are not destroyed. If cells are not destroyed, immunity comes and tries to destroy them. So because of all these factors, inflammation keeps on going there. Why this inflammation is important? It contributes to all diseases. Not only diseases of aging, but also to frailty. This contributes to anemia of older age. This inflammation contributes to reduced hunger. So again, the same thing is given. We'll need not discuss this one. So this is what I told. With the aging, because of chronic exposure to the infectious agent, reactive oxygen species, and other pathogenic stimuli, inflammation gets activated, inflammatory mediators get produced. Because of that, we have so many things. Okay, because of that, we have so many things which happen, like anemia, sarcopenia, osteopenia, like most of the things are the aging, both the diseases as well as frailty. So that was about the non-specific immune system. Then what about the specific immune system? As I already told you, lymphopoiesis, the lymphopoietic system is essential for specific immunity. But with the aging, more myelopoiesis occurs, reduced lymphopoiesis occurs, so there is reduced immunity. When specific immunity is low, there is more chance of infection, there is more chance of cancer, and all the vaccines act by producing more of lymphocytes. When that is reduced, there is reduced efficacy of vaccines. We'll discuss these changes one by one. So this is what I was telling. With the aging, T cell production is reduced, B cell production is reduced, so antibodies are produced less, right? So since I told you, one of the things which happens because of reduced immunity is near cancer, which we discussed earlier. Another thing, they are more prone for infections and reduced efficacy of vaccines. So regarding infections, what is normal in old age. See, you take a urine culture from an elderly person, some culture grows positive, but he is asymptomatic. Can that be taken significant? It cannot be taken significant because there's something called colonization, which is different from infection. Okay, so if you see the urinary tract, if you see the bed sores of some elders, they normally have some organisms, they do not produce any infection. So just because if you send a culture, it is positive, it cannot be taken as an infection. Don't go on giving antibiotics for that because they do not tolerate antibiotics. They do not tolerate any drugs. So there's something called culture stewardship. Not only antimicrobial stewardship, you should follow something called culture stewardship. Now, what is abnormal? So as I already told you, because of reduced immunity, they are more prone for infections. And even though they get an infection, they do not give the symptom of fever. They present with atypical symptom, like they present with confusion instead of fever. Okay, and fever of unknown origin is common. So the definition of fever is different in elders. Usually we say more than 100 degree Fahrenheit is fever, but in elders, we have 1 degree less. More than 99 degree Fahrenheit itself is taken as fever. And I told you fever of unknown origin is more common. So intra-abdominal abscess is the most common cause of fever of unknown origin. We'll be discussing the same thing later also. So regarding vaccines, I told you there's reduced efficiency of vaccine, but still 3 vaccines must be given in elders. One is influenza vaccine or the flu vaccine. Why this is important is 90% of deaths in influenza are in elders. So if you give influenza vaccine yearly, there is 40% prevention of influenza-like illness. There is 60% reduction of confirmed influenza, and revaccination reduces mortality. So even though there is reduced response to vaccination is a must. Similarly, herpes zoster. So in herpes zoster, what is typical of old age is multidermatomal involvement is common. But giving vaccine, herpes zoster vaccine, there is 50% reduction of zoster infection, and there is 67% reduction in post-herpetic neuralgia. It's a painful condition. Now, if you listen to even radio or television, people are advertising about the importance of herpes zoster vaccine. Another most dangerous infection is pneumococcus infection, pneumonia. So adults more than 65 years of age are at risk of developing invasive pneumococcal disease, not only lung. There may be sepsis, endocarditis, meningitis also, and there is 15 to 20% mortality in this group. So vaccine reduces the risk of invasive disease. So even though the vaccine efficacy is reduced, we must give vaccines. These 3 vaccines you have to keep in mind. So we finished about the hematopoietic system and inflammation. Now about the cardiovascular system. So you can see the image. You can make it out basal. This is a normal young heart. This is the aging heart. So you can see here that aged heart is a thick, right? Similarly, this is the normal blood vessel. This is the aged blood vessel. You can see that vessel have thickened, and there's deposition of atherosclerotic deposit. So the same picture, right? A normal blood vessel, but this is a blood vessel which is narrowed by plaque deposit or atherosclerotic deposit. So that's what happened. Aged individuals are more prone for atherosclerosis, and we have already discussed the cell number reduces, but cell size increase. So that's cardiomyocyte hypertrophy, which leads to left ventricular hypertrophy as such, and there's increased pericardial and epicardial fat. So it's just the repetition of the same thing. So what are normal changes which occur? As we have already discussed, there is hypertrophy of the heart. There's fibrosis, collagen accumulation. Because of hypertrophy, LV cavity size decreases. There's shortening of the long axis, that is the heart morphology changes. There is dilatation of the aorta, and there is calcium deposition in the valve. There is coronary artery dilatation. Conduction system becomes weak. These are the normal structural changes. And what happens in the functional changes? Because the heart becomes thick, it cannot pump blood. Remember the word peak cardiac output decreases. That the basal cardiac output may be normal, but following an exercise, they cannot increase their cardiac output. Because the conduction system is abnormal, following an exercise, they cannot increase their heart rate. So following an exercise, their peak ejection fraction declines. And some amount of valvular regurgitation is normal. And we have discussed systolic BP increases. Right. So again, what is normal and what is not normal in the heart? So if some of your relative comes and shows an echo report in an asymptomatic elder, I'm worried about this finding. So which is a normal finding, which finding should worry us. Left ventricular hypertrophy, as we discussed, is a normal finding of aging. Mitral valve regurgitation is a normal finding of aging. And coronary artery calcification, valve calcification, all these are normal findings of aging. And increased systolic pressure is a normal finding of aging. The cutoff is different for BP management. So this is what we discussed in the first slide. Systolic BP increases by 10 millimeters of mercury every 10 years. And these are the normal findings which we can expect. But what is abnormal? What echo findings should make us worry is presence of systolic dysfunction, presence of regional wall motion abnormality, means some myocardial infarction has occurred. And because the vessels become small, they are more prone for developing coronary artery disease, that is heart attack, and they are more prone for stroke. So they are more prone for heart attack. They are more prone for heart failure after heart attack because of the functional changes in the heart. And there's reduced tolerance of acute hypertension. They do not tolerate a high BP. And young individual coming with high BP may be asymptomatic. Whereas an elderly individual coming with high BP, they'll be very symptomatic. So reduced exercise capacity. So for a person to exercise normally, we need bones, muscles, and heart. So many changes occur in the heart. We have already discussed muscle mass reduces with age, muscle power decreases with age. And just now we discussed with aging, the peak heart rate reduces, the peak stroke volume reduces, so they cannot exercise properly, right? Okay, so that's about the heart. Now what happens in the aging gastrointestinal system? Just remember one thing, everything becomes low in the GIT. Okay, everything becomes low in the GIT. So the peristalsis becomes low. As you know, when we take food, the oropharynx should contract, the esophagus should contract, that is peristalsis, and the intestine should go for peristalsis for the normal functioning. So with aging, what happens is the esophageal peristalsis reduces. So the food doesn't enter from the oropharynx to the esophagus. So there is more prone for dysphagia and aspiration. That's what is given here. What happens in the stomach? The same thing. There is reduced peristalsis of the stomach. So the food remains in the stomach for a long time, which means there is more chance of ulceration. What happens in the intestine? There's reduced absorption from the intestine, reduced drug metabolism. What happens to the colon? The reduced contraction, so more prone for constipation. Similarly, some changes occur in the gallbladder. Gallbladder also relaxes. It doesn't contract, so more chance of gallbladder stones in elderly. And what happens in the liver? Liver is one of the organ which metabolizes drug. That is affected. Same thing we have repeated here. So what happens in the oral cavity? These are some of the other changes. Teeth is diseased. There will be dry mouth. Mandibular bone density is lost. So there will be dysphagia, oral dysphagia. Oropharynx we have already discussed. There is slowing. So that can lead to dysphagia. Stomach also relaxes. So increases risk of ulceration. Small intestine, their absorption get reduced. So what all absorption is reduced? We have already discussed vitamin D absorption is reduced. B12, calcium, copper, zinc, fatty acids is reduced. Among these, you should remember zinc because they say supplementing zinc can be helpful for a healthy aging because zinc absorption normally reduces with age. Zinc is also needed for reepithelialization of the gut. But iron overload is common. Iron absorption is not reduced. Okay, please remember that. And B12 absorption is also reduced. So you can see many elders who get happy with B12 injections. Colon, we have discussed the same thing. Colonic motility reduces, so they are more prone for constipation. And there's something called diverticulosis. Liver blood flow reduces, so liver metabolism reduces. Gallbladder stones increase because of stasis. Same thing which we discussed. So due to normal aging, constipation is accepted. Some amount of gastroesophageal regurgitation is accepted. 10% of healthy elders have silent aspiration because they won't be able to swallow their saliva. And this is what we discussed in the immunity part. there is decreased visceral sensitivity and poor sensitivity of clinical examination. So even though they have fever of unknown origin, even though they have intra-abdominal abscess, it doesn't produce pain, it doesn't produce tenderness. So we cannot rely abdominal examination in elders. And what findings in GIT should make us suspect a disease? Diarrhea. Diarrhea is abnormal. Constipation is normal in elderly, but diarrhea is abnormal. Okay. And CA esophagus, we have discussed. Cancer is more common. Increased risk of ulceration, this we have discussed. They are at increased risk of aspiration, and drug-induced hepatitis, pancreatitis, and diarrhea can occur. Right. So since we told GERD is very common in elderly, the most common cause of dysphagia in elders is GERD. Okay, even though there is cancer, strictures are possible. The most common cause of dysphagia in elders is GERD, which is a bit normal. But we have to rule out the other diseases. Similarly, cause of diarrhea in elders. I told you, constipation is common, but diarrhea is uncommon in elders. The most common cause of diarrhea in elders is constipation itself. Right? For example, there may be some stricture of the rectum, colorectum. There may be some mass in the rectum which can lead to a constipation. So with fecal impaction with constipation, the proximal loaded colon cannot absorb more of the fluid and the content of the feces will be a liquid. So once constipation relieves, they'll go for diarrhea. Right? So if someone complains of diarrhea, we have to rule out a chronic intestinal obstruction or a chronic colonic obstruction by doing a perirectal examination. Right? The second most common cause of diarrhea in elders is medications. So diarrhea is abnormal, but still the most common cause of diarrhea is a impacted fecus plus medications. So since we discussed about the gut, we should know something about the nutrition. Both undernutrition is common, and with the current trend, overnutrition is also common in elders. Undernutrition is more common. So again, the reasons are obvious. There are many socioeconomic factors. There is no caretaker, and some physiological changes occur. They don't feel like eating because we have already discussed. Hunger reduces because of increased inflammatory factors. Oral mouth becomes dry. The teeth becomes weak because of old age. Plus some psychological factors are there, and because of comorbid illnesses. Our respiratory system is simple. So the structural changes is alveoli enlarge and they lose their elasticity. Lung is not only lung. The lung is surrounded by the vertebra. The vertebral height reduces, so the entire thoracic cavity size reduces. And the muscles around the respiratory system also become weak because of sarcopenia and dyspnea. They cause some changes with breathing, and the functional changes will decrease FeV1 by FVC. So these are some spirometry findings. We are not going into the detail. There is increased FRC and RV. So more amount of air gets retained in the lung, but they cannot expire the lung properly. And there is DLC, that is gas exchange decreases by 5% every decade after 40 years. There is reduced pulmonary capillary blood flow. What happens because of this? Senile emphysema. Emphysema is like COPD. With old age, some changes occur like an emphysema, even without smoking. Yes, now coming to the next most important system after cardiovascular system, which is musculoskeletal system. Because cardiovascular system and musculoskeletal system together contribute to the reduced mobility and reduced exercise tolerance in elders. So you can very well see here an upright, strong man. So here the muscle mass reduces, their vertebral height reduces, their posture changes. Right? So why musculoskeletal system is very important? It's the most common cause of chronic disability in late life. Around 30% of women and 15% of men over 60 years report inability to lift a weight. And 50% of, like nearly 50% of elders have difficulty with movement, with stooping, crouching, or kneeling. It affects independence. So this also we have discussed. Two changes occur with the musculoskeletal system. One, there is reduced muscle mass. Muscle mass decreases by 1 to 2% per year after 50 years. That's called sarcopenia. And the muscle strength also reduces by 3 to 4% per year. And sarcopenia and dyspnea are components of frailty. Remember, we discussed earlier, there's something called multimorbid aging. There's something called syndromic aging. Frailty is one of the syndromes of aging. So when do you say frailty? Just This is not our topic, but you just know what is frailty. Presence of these 5 components is called frailty. So there should be weight loss, there should be sarcopenia, there should be weakness, which is dynapenia, exhaustion or poor endurance, slowness, and low activity. So many of this comes together, it is called as frailty. We are not discussing that. So these are the changes. Sarcopenia occurs, dynapenia occurs. Why does this occur? So you know very well that the brain is the organ which gives signal through the nerves and neuromuscular junction to act in the muscle. So changes occur in the CNS, changes occur in the neuromuscular junction, changes occur in the muscle. So the changes occurring in the CNS is called motoric cognitive risk syndrome. The brain size itself reduces, as we have already discussed. So because the brain size and premotor cortex reduces, the signal coming from the brain itself is reduced. So voluntary activation is reduced. Some changes occur in the neuromuscular junction. It gets remodeled. And some changes occur in the muscle because of the changes which I've already discussed earlier, because of inflammation, because of reactive oxygen species, reduced amount of testosterone, reduced amount of protein, changes in calcium. So all these things leads to the muscle changes. So you can see the neuron becomes small. To compensate for that, another neuron grows into the cell. This is what happens, causing remodeling. Need not know the details anyway. So that finishes muscle. Okay, we have sarcopenia and dynapenia. Again, bone, we discussed the same thing. Bone mineral density decreases by 0.5% every year after 30 years. If you see a bone, we have so many cells. The bone forming cells are called osteoblasts. The bone destroying cells are called osteoclasts. So with age, what happens? Osteocyte increases, osteoblast decreases. We have already discussed vitamin D is very important. Vitamin D reduces in old age. PTH is the bone destroying hormone. PTH increases and estrogen reduces and inflammation. So all the cellular changes, endocrine changes, which I discussed earlier, is going to lead to osteopenia and osteoporosis. So how to prevent that? Vitamin D, daily 600 international units of vitamin D. So that was about the bone. What happens with aging joint? So joint is another thing which most people complain of. But we have to differentiate between whether the change is an aging joint or an osteoarthritis. So again, we are not discussing the entire thing which happens. Remember, we told about cross-linking. In aging, collagen cross-linking increases, so collagen stiffness gets increased, but there is no change in the underlying bone. Whereas in osteoarthritis, the underlying bone also becomes destroyed. Okay, so maybe differentiated in X-ray. Similarly, what happens with the aging disc? If you see the MRI or CT of most elderly individuals, some changes will be given in the disc, like disc degeneration is present. Okay, disc dehydration, there's a disc herniation present. But please remember, it doesn't correlate with the patient's symptom. Patients having severe back pain, there is a mild disc bulge due to aging. We cannot attribute a symptom of back pain due to aging. I already discussed back pain in elderly individuals. We have to suspect secondaries or myeloma rather than a disc problem. Okay, definitely disc changes will occur. The disc dehydration will occur. Disc becomes small. Their vertebral height reduces. But it has to be, it doesn't correlate with the symptoms. Right. So musculoskeletal system was very important. Now brain is also very important. So again, you can see the image. This is the normal, healthy, young brain. See the elderly brain. So what happens in the elderly brain is the brain mass reduces, right? So volume loss of the brain occurs. Then cortex becomes thin. The gap between the brain and the skull increases. This is problematic because when the gap between the brain and the skull increases, there is so much of gap. So the blood vessels become weak there and they can rupture and predispose to bleed, right? So enlarged subarachnoid space predisposed to SDH. So if you see the CT brain report, they'll be giving age-related cortical atrophy, right? This is what it is. The brain size normally shrinks in old age. But if the shrinkage is very abnormal or the ventricular cavity size increases more, beyond a particular amount, we have to suspect diseases like normal pressure hydrocephalus. So this is what we are discussing. So the structural changes is after 60 years, brain mass decreases by 1% per year. Some changes occur in the neurotransmitters. Some changes occur in the cerebral blood vessels, so they are more prone for stroke. This also we discussed. Some changes occur in cognition. Will come one by one. So structural changes I have just shown you. Regarding neurotransmitters, we have 4 important neurotransmitters. Acetylcholine, it reduces in old age, leads to Alzheimer's disease. Dopamine transmission reduces in old age, leads to Parkinsonism. Serotonin transmission reduces, leads to depression. Glutamate reduces, leads to Alzheimer's, Parkinson's. Now cognition. Cognition is the thinking capacity or the function of the brain. So this many of us will have a doubt. My father has lost his memory. Is it normal? Or is it Alzheimer's? What should I do? Remember, with aging, the normal thing which occurs with aging brain is their processing speed becomes slow. Okay, their processing speed becomes slow. They do everything slow. Regarding intelligence, their crystallized intelligence is normal. That is, whatever they have gained from experience, they do it well. But there's something called fluid intelligence. A problem-solving capacity or a flexible reasoning, they decline. So we see most elders are rigid. They don't change their ideas. So what is gained from experience, they are good at it. But what is new, they don't learn. Similarly, they don't learn new information. Right? So learning new information is called declarative memory. They have reduced declarative memory. But whatever they have learned already, semantic memory, procedural memory, like if you ask them to ride a bike even at an elderly age, they will do it. If they don't have sarcopenia and anemia. And their attention decreases, distractibility increases. Okay. And this we would have observed, word finding difficulty. They find it difficult to remembering terms, but it improves with cues. If you give them a small clue, they'll tell the name. So why these terms are important to know is, if you are assessing the cognition of an elder, we have to differentiate whether it is normal or whether it is a process part of Alzheimer's disease, because we have separate interventions for that. Word finding difficulty that doesn't improve with cues indicates Alzheimer's disease. To say one example. It's the same thing which we discussed. So what is preserved is regarding intelligence, their crystallized intelligence is normal, fluid intelligence is abnormal. Sustained attention is normal, divided attention. They can't focus on 2 things at a time. Regarding executive function, novel executive functions they can't. And memory, I told you, their old memory, remote memory, procedural memory remains normal. Whereas declarative memory, that is learning new information, is abnormal. And most of the language is abnormal. So they are normal. They have only a spontaneous word finding difficulty with improves with cues. And most important thing is their reaction time decreases. They do everything slowly. So why we discussed cognition bit more detail is there are some tests for cognition, right? So when you are assessing an elderly individual, one of the components of elderly assessment is their cognitive assessment. So we have many tools for that. This one small example, MOCA, Montreal Cognitive Assessment Tool. So they have given the instructions there. So we have to follow that, and based on that, scoring is given. This is just a small test. Like this is called Stroop test or a Stroop word color test. So this chart will be given to them. They should read the color of the word and not the word as such. See here, the word is purple, color is green. So they should read it as green. This one as blue. This one as red. Okay. So this screenshot is taken from Geriatric's textbook. So many changes occur in the brain. Can we prevent that? So this was one question which many people ask: how to prevent aging, or how to prevent the changes of age? So evidence says these things are good. So physical exercise improves cardiovascular function, reduces brain volume loss, and stimulates neurogenesis. And doing outdoor activities stimulates neurogenesis, stimulates synapse formation, increases brain capacity. Regarding diet, remember calorie restriction. So calorie restriction and take more of monounsaturated and polyunsaturated fatty acid, vitamins, antioxidants. Antioxidants include vitamin C, zinc, etc. And treating existing medical condition. This is also very, very important. I already told you with age, there'll be dyslipidemia, diabetes, and hypertension. If you treat that, that is also going to protect the brain. So, and minimize environment, like reduce the stress, right? So, exercise, calorie restriction, and treating pre-existing medical condition and outdoor activity have been proven to reduce age-related changes of age. So, major thing is completed now. Just small things. The kidney. This also we have discussed. Regarding structure, the kidney size reduces. Podocyte is a part of the glomerulus. That also reduces. And more scar gets formed. That is increased age-related glomerulosclerosis, thickening of basement membrane. So what is the physiological change which occurs in aging is the blood flow to the kidney reduces, filtration of the kidney reduces. So if the kidney doesn't filter, whatever water or whatever excess solute intake is taken by the person will not be processed by the kidney. They go for more of volume overload. Similarly, many changes occur in the tubular function. There will be changes in the electrolyte and acid-base handling. They don't filter what is taken. They don't excrete what is taken. And this is the value, right? GFR decreases by 10% per decade after 40 years. Remember, kidney is the organ which excretes most of the drugs. So problems will occur even in drug metabolism. So with the aging, there's difficulty in handling salt and water overload because of the reduced renal reserve. That is reduced filtration and reduced tubular function. And there is reduced drug excretion. But what is abnormal with the kidneys? A high creatinine is pathological, a proteinuria is pathological. Okay. So urinary tract also changes. So we have discussed a syndrome called as incontinence, which is one of the aging syndrome. So why they are prone for incontinence, urinary incontinence? Because they have increased volume at the first desire to void, and there is reduced bladder capacity. There is more urine production. So bladder becomes small, urine becomes more. They do not sense the urine properly, and their detrusor bladder does not contract properly, and sphincter does not function. Because of all these things, they are prone for urinary incontinence. So again, why we should know all these things is when an elderly comes, incontinence is very common because of all these normal physiological changes. So we have to ask this questionnaire. There's 3 IQ questionnaire which should be asked. During the past 3 months, did they have incontinence? If they had incontinence, in what instance they had incontinence, and which was the most common trigger for incontinence? Based on that, we can find out the incontinence. We are not going to discuss in detail. Incontinence is common in elderly because of the changes in the urinary tract. Now, since we have finished about liver and the kidney, liver and kidney are the 2 organs which deal with drugs. So I already told you the blood flow to the liver decreases, drug metabolism of the liver becomes abnormal. The blood flow to the kidney reduces, the metabolism of the drug in the kidney reduces. So we should be very careful in giving a drug. Okay, so treatment plan should consider coexisting diseases. Also, they have more diseases, so polypharmacy is more common. So whatever medicine we start, it should be started as per the ALARA principle, as slow as reasonably achievable. So start with the lowest dose possible, titrate it slowly, and you review the medicines very often so that unnecessary medicines can be cut off. Okay, now we have finished individual system. Now, the crux of physiology is something called as homeostasis. Okay, the crux of physiology is homeostasis. Like whatever change occurs in the body will try to adjust to that. It's called as homeostasis. In elderly, homeostasis is affected. That is called as homeostenosis. So homeostenosis is diminished capacity to respond to various homeostatic challenges like changes in temperature, orthostasis, that is changes in position, fluid overload, and dehydration. And since the function and structure reduces, there's something called reduced physiological reserve. This is what we are discussing throughout. We discussed renal mass reduces, the cardiac output reduces, peak cardiac output reduces, neuron number reduces. So because of the reduced physiological reserve and loss of complexity, some changes occur. They do not have the capacity to deal with the stress. The other things we are not discussing. See, this is an example. With reduced ambient temperature, a normal body should increase shivering and it should increase heat production, which is normal. But in elders, even with reduced ambient temperature, that is even in cold scenario, they do not have the sensation of cold. They do not have shivering intensity because muscles are reduced in mass as well as strength. So shivering is less common. So they do not produce heat. So they are more prone for injury due to hypothermia. Similarly, with elevated body temperature, there should be increased sweating. But because of the nerve changes in aging, there is reduced sweating. And there is reduced ability to raise the cardiac output. So they also are more prone to problems with high ambient temperature. So with orthostasis meals or hypovolemia, they should increase their BP. Like when they stand from the lying down position, they are at increased risk of hypotension because of autonomic failure. So with hyperglycemia, we discussed their baseline sugar is high. After food, it becomes very high, but it takes time to come back to normal. So they are at high risk of fluctuations, hypoglycemia and hyperglycemia. And we discussed about the fluid challenge because the kidney cannot tolerate the salt and fluid overload because of glomerular changes and tubular changes. So these examples are examples of homeostenosis, right? So structural changes occur, functional changes occur, they predispose to disease. Other than disease, a normal physiological change cannot be tolerated by them. This is called homeostenosis. So now let's put it all together. So why through the last half an hour, 40 minutes, we discussed about all changes in every system is one, only if we know the changes, we can know how to assess and what is normal and abnormal. So vision and hearing are usually affected in elderly. So vision and assessment of the elderly is not only history taking, physical examination. Vision assessment, hearing assessment, nutrition assessment, and urinary incontinence assessment, the 3 IQ questionnaire which I told you. We should assess them for their muscle power, balance, gait, fall risk, and cognitive assessment. Some example of MOCA I told you, and their functional assessment, and even their drug chart has to be seen. Even that is a part of assessment of elderly, right? So vision and hearing, nutrition, urinary incontinence, balance assessment, cognitive assessment. Some of these will be discussed in subsequent sections. And we have something called WHO ICOP screening tool. Okay, it's a simple screening. It's only questionnaire which even staff nurses can apply to elders more than 65 years so that they can pick up if something is abnormal. See, cognitive decline, just a question. We can ask them to remember 3 words and ask them to recall the 3 words. We can ask them 2 questions about orientation. If things are wrong, we can give them a scoring and we can label them as cognitive decline. They have to be evaluated further in detail. There are questions on mobility, there are questions on nutrition, vision, hearing, depression. Right? Remember that there is an ICOP screening tool. So just end part of this. So I told you about the telomere theory of aging. When telomere reduces, genomic instability, cells die, they go for aging. There's something called evolutionary theory. They say for organisms which live for a longer time, they age later. For example, smaller animals, they die at 2 years because they are killed by other organs. So from time immemorial, the organisms which are killed by other organisms have a shorter lifespan. They age early. Whereas humans, they die a little late because they are not destroyed by other organisms. Some big organisms like whales, they are not destroyed by anyone. So they live for long, they age late. There's something called evolutionary theory. And mutation accumulation theory, I was telling you. As time goes on, they are more damaged by infections, they are more damaged by ultraviolet rays, they are damaged by reactive oxygen species, free radical injury. So all this occur that accumulate and lead to changes. And mitochondrial dysfunction, cellular senescence, and dysregulated nutrient sensing, changes in nutrition can cause theory. So why we should know the theory is there a method to prevent or reverse aging? I think it's $1 million question. But what evidence says is calorie restriction and intermittent fasting has been shown to increase sirtuin's FGF21 AMP and reduce aging. Physical activity, it reduces chronic inflammation, IL-6 levels, and it can reverse or prevent aging. And some drugs are still being tried. Even metformin is in trial, whether it changes aging, because it changes the mitochondrial AMP signaling. Okay, this is about healthy aging. These things can help to have a healthy aging. But what about multimorbid aging? So vaccination, as I already told you, even though vaccine response is poor in elders, we must vaccinate them. And vitamin D, I told you, is very important to prevent osteopenia, cognitive stimulation, some hormone supplementation, testosterone have been tried. Aspirin is an NSAID. It's an anti-inflammatory, it reduces cancer. And vitamin E, creatine, all these are antioxidants. They have a role. Zinc, I told you, zinc is not absorbed from the intestine in elders. So zinc supplementation is very important. Okay, selenium can help. And treating age-related diseases can prevent or reverse aging. Right? So this is summarized from Harrison. So there are 7 commandments which you have to remember. Aging is not a disease. Okay, normal or healthy aging does not usually cause symptoms, but increases susceptibility to diseases because of homeostasis. It also increases the risk of death, right? Healthy aging. So regarding multi-orbit aging, including cancer, we have to be evaluated and manage that properly, because treating them is one of the intervention to prolong life. And regarding syndromic aging, urinary incontinence, falls, frailty, they are not usually assessed. Many people don't have the awareness of that. So I have created that awareness in you. It is commonly underdiagnosed and undertreated. So screening tools are needed to pick them up. And exercise capacity is reduced because of cardiac, vascular, muscular, and skeletal changes. We should be watchful of them. And cognitive and affective disorders are common. They are underdiagnosed and oversensitized. So we should have screening tools to identify them and help them. And iatrogenic illnesses, especially drug problems, are common because of the changes in GIT, hepatic and renal function. So prescription monitoring is also very important in elders. And functional ability, like improving sarcopenia and undernutrition, are key goals of care. So these are my references. So the 2021 to 2030, this decade is called United Nations Decade of Healthy Aging. Now, you know the epidemiology. Now, more aged people are there because of healthy lifestyle and better medicines. So in future, a situation may come where elderly population is more than the younger population. So we should focus more on healthy aging rather than developing a multimorbid aging or syndromic aging. Right? So I think this talk may help to sensitize us. Thank you.